and welcome to the inaugural Stewart Healthcare Network Education Series. My name is Dr. Donna Milovitz, and I am the Regional Vice President for Stewart Healthcare Network for Utah and Arizona. And it really is my privilege and pleasure to be with you this morning to be talking about two really important topics for our ACO, which really are the bread and butter of what we do every single day, which are risk adjustment and CPTII coding. So thank you for being here, for signing in, and for your partnership in caring for our patients, because it's important. Everything you do every day does meaningful change in people's lives. So I want to talk a couple of minutes about just some housekeeping issues for all of us, and then we'll jump into to the meat and potatoes of the presentation. So first, we are being recorded, and that this presentation will be available for those providers who were not able to join us today. The content topic is going to be geared towards both physicians and advanced practitioners. And we will have other training for clinical support teams, billers, and coders as well coming up on the 18th. If you could please make sure that your microphone is on mute, that would be helpful for the presenters to not get additional feedback. And then lastly, that if you have any questions, which we'll go over in just a minute, we do not have time today to do that in a live interactive sessions. So what I'm requesting that you all do is to email me, and I will send out content to the entire group. So with that, if we could advance the slide, please. We do have accreditation to present today. There's 1.0 AMA PRA credits available, and we're excited to be able to present that to you. Next slide. Again, there are some learning objectives today that you can read, but again, we really want to define risk adjustment and why it's important, explain how to implement both risk adjustment scoring as well as CPTII coding, and then best practices for both. Next slide. We have also been successful in getting mock points for those of you who are in the pediatric world and internal medicine world for our continuing accreditation towards our board examinations. And then last slide. To obtain the CME and mock credit, you need to go to this website that's listed on the screen, or the QRL code that's in the corner of the screen. You need to answer some questions regarding content and feedback. You'll hit the submit button on that, and that will then generate the back-end process for us to be able to get you your CME and mock point credits. If you have any questions about this, you can certainly feel free to reach out to me. Next slide. And then lastly, this is my email address, my first name, Donna.Milovitz@stewart.org. If you have questions along the way, please jot them down and email me. And again, I will distribute these to you. And then if you have any problems getting your CME or mock points, please reach out to me. Lastly, I'll make a shameless plug for the markets, and saying that if there's other educational content that you would like to see, we will be doing these educational series for both physicians and support teams on an ongoing basis. Physician and AVP content will be quarterly with CME and mock point credits. So if you have anything that's a burning desire to learn, we would be delighted to entertain those ideas. So next slide, please. So with that, I have the pleasure of introducing Tasia Henke today to you. Tasia is a proven quality leader with many years of experience across many facets of healthcare, from acute care to first responder to operational settings. She began her healthcare quality career as a hospital phlebotomist and a lab assistant back in 1986. I love to hear people's stories and how they get to this point. and then moving into management over time. She lives in Phoenix with her family, having shifted her career path to working at Steward in Health Choice, Arizona, as a claims trainer back in 2006. She moved into operations in 2008 as a supervisor, and then ultimately transferring into the quality management team as a senior management of accreditation in 2013. In 2020, she took an additional role as senior quality manager of Steward Health Choice of Utah, and then the ACO quality of senior role manager and clinical reporting in along the way. Tasia is just a plethora of information and expertise regarding CPT2 coding, and I'm excited to partner with her to present today this important aspect of care management and quality. So with that, Tasia, I'm going to let you take it away.
Good morning. Thank you, Donna. I appreciate that warm welcome. Good morning, all. Thank you for your time today, and I'd like to start off my presentation by giving you the purpose of my mission here, and that is to help you close gaps in care using CPT2 codes. Basically, during this time with me, I'll be describing what is a CPT2 code, which payers allow them, what gaps can be closed using them, and really doing a deep dive on each measure and the documentation needed in order to close the gap. Next slide, please. One more. Thank you. What are CPT Category 2 codes? Basically, they're non-reimbursable tracking codes, which we use in performance and quality to facilitate data collection for the purposes of performance measurement. As practitioners, and I know that within your practices, you are always getting calls from different insurance payers, the ACOs, what have you. Can you give us a moment of your time? We'd like to discuss, how we can help you close gaps in care, et cetera. This is one of the ways that across all payers, et cetera, that you can accomplish this. Why it's so important is that it decreases the need for us to request member records for that same information. Now, I'm not saying that this is applicable in all cases, but there are several outcome measures that across all payers that we track. And this actually helps us capture the information through your claims process. Capturing this data also helps us drive performance improvement, not only within our areas, but it helps us help you in order to service your member, or your patient, and to ensure that they are being driven towards the quality health care that they so need. And it also helps drive direct star rating improvement, and it helps identify more quickly the gaps in care that can be closed. You bill a CPT code the same way that you do a regular CPT code, like an evaluation management code, which you all are familiar with. Our CPT2 codes describe clinical components, which are usually included in that E&M or clinical service, but they are not associated with any relative value. And one thing that we should be aware of is that and this will be more directed towards the billing team, those are normally billed with a $0 charge. So basically, you're not getting any reimbursement for it, but the return on investment speaks volumes for not only you, the provider, but your patient as well. Next slide. Which payers in Arizona and Utah allow CPT2 codes? Regionally, I tried to identify the payers within Our ACO that we have confirmed use of CPT2 codes to close quality gaps. It's Health Choice Arizona, Humana Arizona, United in Utah, Health Choice Utah, Humana Medicare Advantage, Regents, Commercial and Medicare Advantage. Those are to name a few. Next slide, please. Which gaps can be closed? Well, our HEDIS, which is the Health Information, Healthcare Effectiveness Data Information Set that is produced by NCQA, they define several measures which they would call as outcome measures. Some of those include controlling blood pressure, hemoglobin A1c screening, good control, poor control, diabetic eye exams. Next slide. Diabetic neuropathy, care of older adults, medication reconciliation. Those are a lot of the outcome measures that we track within our ACO, but there are a couple of others that that the other pairs may identify as well. Could I flip back to the previous slide real quick? I'm sorry, I overlooked that. If you'll draw your attention to hemoglobin A1c testing, during the last few weeks, I've done a deep dive analysis on provider billing and things that we're seeing coming in through our doors. And one of the things that I readily identified was the continued use of a CPT2 code 3045F, which is hemoglobin A1c. It was used to say 7, most recent 7 to 9. That was actually replaced by new CPT2 codes 3051F and 3052F. And what will happen most likely, if you continue to bill 3045 codes, now because it's a retired code, the claim may deny. So I just wanted to kind of point your attention to that. So just again, 3051 and 52F are now the replacement codes for 3045F. Next slide. And go ahead and advance to one more. Now this is more of a deep dive into each CPT2 code, category 2 code, which closes an outcome measure. So our first one is controlling blood pressure. Some of the documentation that I would need to see as an abstractor, for instance, looking for this information to help close your gap, would be, of course, the CPT2 code on the claim, diagnosis of high blood pressure or DM2. If you happen to be measuring multiple blood pressures on the same data service, whenever you are recording your CPT2 codes, choose the lowest systolic and lowest diastolic and submit those codes. It does not have to be from the same reading. It just has to be on the same data service. And lastly, if your blood pressure reading is taken on electronic device and transmitted to you by the patient, that's fine. It just, within your documentation, you need to state that the blood pressure was taken by an electronic device and that you interpreted and that you provided an interpretation within your notes. The one thing that I might add here is that blood pressure is taken manually with just a normal blood pressure cuff and a stethoscope will not close this gap. It has to be taken on an electronic device if it is transmitted to you by the patient. So this is something that can be done through telehealth. Next slide. Moving on, hemoglobin A1c. So, okay, some background here. Thank you. Your CP for hemoglobin A1Cs, this will close 3 gaps or 3 measures, depending on what it is. So hemoglobin A1c testing, hemoglobin A1c good control, or poor control patients. So what we would need to see in there again, the CPT2 code on your claim. You would need to identify the most recent A1c test that you performed in the measurement year, that would be normally billed through your claims encounter or through maybe supplemental lab data or what have you. And then you need to ensure that your chart information, your documentation, includes the date and the result of the most A1c test. That'll be something that we're looking for when we're abstracting your chart. Next slide. Here's a big one, nephropathy screening. So there's a couple of ways we can close the gap with, for neph. You can do it through documentation of, one, diabetes. That a diagnosis of diabetes, of course, is one of the things that helps close the gap, your CPT2 code. And then we would need to see evidence of one of the following, either through claims data or your medical record review. So either I can close it either way. So, but within your record, you do need to show documentation of the nephropathy screening or a monitoring test, either a urine test for albumin or protein, and it needs to include the date it was performed and the result. Or we can do nephropathy as evidenced by any of the following during the measurement year. It could be diabetic nephropathy, ESRD, CRS, renal insufficiency, proteinuria, renal dysfunction. Or another one is an ACE or an ARB dispensing event. You can actually close this through a pharmacy claim. If your patient is taking an ACE or an ARB, go ahead and record that. It's code 4010. That is probably one of the more underutilized codes that I've seen as well. Next slide. Diabetic eye exam. So again, we need a diagnosis of diabetes, the CPT2 code, and then we would need documentation of patients who've had a diabetic retinal eye exam during the measurement year, which is 2020, to include the result and the data service, or a documented negative retinal eye exam with no retinopathy identified that was taken in the prior measurement year, so 2019, which would also need to include the result in the data service. Please note that that retinal eye exam has to be performed by an ophthalmologist or an optometrist. So basically the CPT2 code that you would select would, if you look, you've got kind of an extensive list of different ways you can close the gap. So you can either do it through if you're reviewing the patient's medical records may be submitted to you from the ophthalmologist or optometrist as part of the continuity of care stream. You can select one of the different ways that possibly you got that information, and you can actually get credit for reviewing it and noting it in your chart, and that will also help close gaps in care. Next slide. Care of older adults. So huge, such a great area of opportunity for our older adults in our Medicare population, especially. So basically, when you're doing your annual wellness visit for Medicare, you just the Care of Older Adult measure, which has 3 submeasures associated with it. Pain assessment is one, and what you would need for that is, of course, your CPT2 code, and then documentation that the patient was assessed for pain. And then you need to include the result, either positive or negative findings, and the date of the assessment, as well as which kind of tool you use to do that assessment. Next slide. Another COA measure is functional status screening. So this is where we start talking about activities of daily living, or you would assess those, and you're assessing the patient against those. For normal ADLs, you would want to note at least that you address 5 of the following: bathing, dressing, eating, transferring, using the toilet, walking, that kind of thing. And then you'd also want to do a notation of IADL, instrumental activities, the activity of daily living, sorry. And you would need to document at least 4 of those, that you assess those, that shopping for groceries, driving or using public transportation, cooking, laundry, that kind of thing, as well as the results of the assessment using a standard functional status assessment tool, please document the date of the assessment, the results, and the type of standardized functional status assessment tool that you used. Next slide. I provided just a quick rundown of some different tools that we can use for a functional status assessment. Next slide. Medication review. This is a big one. So it's so important, as you well know, because, you know, some of your patients see like multiple physicians. And one of the most important things is making sure that their medication lists are reviewed and reconciled. And whenever you are doing this assessment during your annual Medicare visit, please do notate within your chart that both of the following were done during the same visit during the measurement year, and it was performed by the prescribing practitioner or a clinical pharmacist. And those would be at least one medication review and the presence of that medication list in the medical record. So be sure you document that date of the medication review and ensure that that list is contained within your record. And a coding tip, use both 1159F and 1160F when billing the colon medication measure. That is actually suggested guidance for that one. Next. And it looks like lastly, we have medication reconciliation post-discharge from inpatient acute or non-acute stay. So what that needs to include is somewhere within the medical record that there is documentation of medication reconciliation conducted by the prescribing practitioner, clinical pharmacist, or registered nurse on the date of discharge through 30 days after discharge from that acute or non-acute inpatient stay. That documentation within, let's say, your office chart must include evidence of that med reconciliation and the date it was performed, and any of the following below can meet the criteria. And then your CPTII code is 1111F, just saying that the discharge meds were reconciled with the current med list in the outpatient medical record. Next slide. Just some reminders to help you while you're addressing gaps in care. When you are looking through your EMR, or if you are doing this manually, make sure that you address either capture or dismiss recommendations regarding quality measures due in the patient records. What that means is if a patient is due for a screening or what have you, please help us close measure gaps in care by ordering and scheduling this annual wellness visits or physicals for any patients still needing the quality measures closed during the measurement year. If the patient's due for colorectal cancer screening, refer the patients for a colonoscopy or order a Cologuard, give an occult blood card if necessary, and they can collect it at home. If they're due for mammogram, please refer or give an order for it. And whenever you ask, when you're doing the patient interview, will you please ask the patients when and where they had a quality measure completed? Let's say you're just ticking through your list, and then have you had a mammogram or an eye exam or what have you? Please note the provider as well as a date if they have it, or even an approximation. It helps us be able to have a little bit easier time tracking down that record. Lastly, I'll close by thanking you for your support in helping steward close gaps in care for all of the folks that we serve across the country. This is been a passion of mine for many years, and I do appreciate your partnership. And with that, I will hand it back to Donna. Thank you so much for your time today.
Tasia, thank you so much for bringing us through the CPT2 coding. Wow, I know every time I hear presentations such like this that I learn something new, and hopefully this information is empowering all of you that are here today to be thinking about as we come to the end of our calendar year and our contract year with our risk-based contracts, that that's important to be thinking about CPT2 codes in our practice, as well as, how do I incorporate this into the cadence of my workflow every single day? So I'm going to pivot now to another really important aspect of our quality contracts, and that is risk scoring. And I have, again, the pleasure of introducing another power hitter from our national team at Steward Healthcare Network, Dina Post. Dina is the manager of risk coding and is a certified risk coder herself. She has a bachelor's degree in business administration and started her career as a provider network within the New England Quality Care Alliance in Massachusetts. Her career started with Steward back in 2013 as a local chapter manager in 2 of the Massachusetts markets, working on quality care retention and provider retention. In 2016, Dina was asked by the then Steward Healthcare Network medical director to move into a new role within the organization, which really focused on educating the entire network on risk adjustment. So she now has a team of 14 risk coders who audit medical records, looking for any missed opportunities in risk coding from a diagnosis standpoint. I can't think of a better person to present today of the second really important aspect of making sure that we're leveraging our risk contracts to our fullest, which is risk adjustment coding. And with that, Dina, take it away. Dana, we can't hear you, so if you're still on mute, I need you to come off mute, please. So we're going to wait just another minute here to see if Dina can get back to us. Slight technical difficulties. I feel like I need to tell a joke or something at this point for the dead space, but I'm gonna hold firm. As we're waiting for Dina to get online so that we can hear her, I'll just remind everyone that if you had any questions regarding the CPT2 information that you just received, that again, the best way to get that information to me is my email, donna.milovitz@steward.org. I will distribute all of those questions and answers to the entire group so that you have that information, and your practice liaisons, as well as local network manager and provider network managers, will be able to distribute that as well.
Apologize. Can everyone hear me now?
Yes, we can hear you. Phew! I was getting nervous that I was going to have to present this.
I am so sorry. I was not on mute, but it wasn't working, and I had to redial in.
It's all good. You're here now. I'm gonna sign off and let you
Always technical difficulties. So I just wanted to thank everyone for joining. As Donna said, risk adjustment is very important to our risk contracts and making sure we're closing diagnosis coding gaps because they do actually help set the budget for our risk contracts. So that being said, next slide. So I am actually going to go over during this presentation, what is risk adjustment? How do we calculate risk scores? What are examples of risk conditions within the Medicare population, the Medicaid population, and specifically the pediatric population as well. And also go over documentation guidelines and what is really needed to support risk diagnoses coding. And then I do have a couple of case studies at the end. So what is risk adjustment? It's a financial offset that recognizes the higher costs for caring for patients with certain conditions. So instead of, just fee for service, the sicker the patient there is, the costlier that patient will be. So it levels a playing field in risk-based contracts performing against the budget. So risk adjustment depends on complete and accurate reporting of a patient's health status and the required documentation to support those diagnoses codes. This must occur at least once per calendar year, so the payers recognize the individual still has the condition. And I know that may sound strange, but the budget resets yearly. So we're starting at, the risk score starts at a baseline again, and we need to tell the payers that this patient still has an amputation or still has diabetes. This information that we submit to the payers on claims is used to predict costs in the following year, or depending on the insurance, the current year. And therefore, the budget set is appropriate. Capturing a patient's chronic condition on a yearly basis, not only does it help set the budget, but it also identifies disease management programs, and it allows us to identify patients that may need that, whether it be through the insurance company or whether it be through Steward Healthcare Network. We are able to determine and get those patients involved in those programs. Next slide. So risk score development. So every patient that is in our risk contract has a risk score that's known as the risk adjustment factor in the Medicare population, but it's known as a health status adjustment in commercial and Medicaid. So each patient at baseline has a risk score that starts with their age, their demographic, and whether they're dual eligible, having both Medicare and Medicaid. So age and demographic come into play because an 84-year-old woman versus would start out at baseline with a higher risk score than a 68-year-old woman, just because there's more risk with the 84-year-old woman. And then every chronic condition that is captured throughout the year just adds on to that risk score. And that risk score gets set at the end of the year and determines what the budget should be for that patient, and it hopefully predicts the likely costs that the patient will have throughout the year. Failure to capture a risk diagnosis in the current year will result in decreased budget for either the current year or subsequent year. So it resets yearly for Medicare, Medicaid, and commercial products. For Medicare, anything that you capture in this current year of 2020 actually sets the budget for the following year, 2021. But in commercial and Medicaid, anything that you capture this year for risk diagnoses actually sets the budget this year. So this process actually places an emphasis on accuracy of diagnosis coding rather than the volume of visits. Capturing a condition more than once a year is great if you need to assess it more than once a year, but it will only count toward the budget once during that year. And that's why, we always push the annual wellness visits, because you have more time to actually go through a patient's chronic conditions than you would at a sick visit. However, chronic conditions can be captured at sick visits if it affects your medical decision making in treating that patient. An example is if a patient comes in, for upper respiratory or a cough. If that patient also has COPD, that would be something that goes into your medical decision making on how you treat this patient. So it would be good to capture that at that visit. Next slide. So this is an example of minimal versus optimal documentation and coding in a patient and how it affects the budget. These numbers are for illustrative purposes only, but some of it did come from Medicare numbers because they actually do release risk score information. So this patient, date of birth 1934, she's a female. Her clinical picture is that she has diabetes, she has CKD stage 5, she has COPD, and congestive heart failure. If you look over to the left, this is an example where a patient had a visit and there were no conditions documented that actually risk adjust. So at baseline, we get a risk score based on the fact that she's an 84-year-old female and she's dual eligible. So that leaves us with a total payment of around $7,000 that's set for that patient for the year. There's some background noise. If anyone's not on mute, could they put themselves? Thank you. So the middle column actually shows some conditions were documented, but not to the highest specificity. So once again, at baseline, they get that baseline demographic score and age. COPD has been captured. There is a risk score associated with that. Type 2 diabetes was captured without complications. We do know this patient has chronic kidney disease, stage 5. That was not documented in this visit, and neither was congestive heart failure. So we are left with a $12,000 budget set for this patient. And then if you look over to the right, all conditions were precisely documented. The baseline score, the COPD was captured. The type 2 diabetes was linked to its complication of chronic kidney disease. And when you link complications of diabetes to the diabetes, there is actually a higher risk value associated with that because of that complication. And then, if you have type 2 diabetes with CKD or type 1, the stage of the CKD also needs to be captured, which also adds additional risk value. And then the chronic diastolic congestive heart failure was also captured this visit. Not going to go into too much detail about this disease interaction, but I will tell you that CMS at the end of the year will add additional risk score if a patient has congestive heart failure and a comorbidity like diabetes or COPD or other types of, including cancer. So you don't, as a provider, have to link CHF to anything here, but they will do it for you if you've captured both at least one visit throughout the year. And it doesn't have to be in the same visit. So as you can see, the total payment or budget set for the year for this patient is over $24,000. So you can see a big difference between, making sure you're capturing these chronic conditions throughout the year versus not capturing them and how the budget is set. This isn't the only thing that goes into setting the budget, because that may seem very low to cover expenses for a patient that has that many conditions. Other things go into it, like premiums and other things, but this helps a lot in making sure the budget set is enough to cover expenses. Next slide, please. Thank you. So this is just an example. It's the same scenario. I just used pediatric conditions. I know there's a lot of pediatric patients within your market. So I'm not going to go over every specific thing, but not capturing obesity for a patient who actually has a BMI greater than the 99th percentile. And juvenile arthritis was not documented. In the middle column, the provider captured obesity unspecified, even though, the BMI was greater than the 99th percentile. So you're not really, getting anything there. And arthritis was captured. And then over to the right, the correct diagnosis of morbid obesity based on the BMI was captured. So that shows you, once again, how important it is to be accurate with the diagnoses based on the medical documentation you have. Next slide, please. So the Medicare risk adjustment model is called the HCC model. All of the diagnoses associated with the Medicare HCC model are actually published. And there's about 9,500 conditions, none of them that you have to memorize or know all of them. I couldn't even do that. But, it is on the CMS website. We do have cheat sheets of the most common risk adjusting conditions in the HCC model. The next slide actually just gives you a lot of the common ones. So if you could go over to the next slide. So these are, obviously the most common ones that we do see. I won't go through all of them, but, diabetes, CHF, CKD, PVD, COPD, morbid obesity. So morbid obesity and major depression are two of the most common diagnoses that aren't being captured when they are clinically relevant. So just something to watch out for is making sure you're looking at that BMI, at least once per year to see if that is a condition that needs to be captured. And major depression, I know that, psychiatrists, they may be seeing psychiatrists for care, but at least on an annual wellness, if you could just assess, all of these conditions, even if it's to say that, the treatment plan is they're being followed by, a psychiatrist and they're on whatever medication for it. Next slide. And this is just a second one. I will say that dementia wasn't one of the risk adjusting conditions prior to October of 2019. It is now in the HCC model. So that's a new one that's been added. Could you actually go back one slide? I just want to say something about chronic kidney disease, sorry, that I missed. So as of October 2020, ICD-10 has actually split CKD3 into two stages, stage 3A and 3B. So you're going to start seeing, if you haven't already in your EMR, asking to add an additional number after the N18.3. It's either going to be a 1 or 2, and it's split between the GFR level. So I believe it's 45 to 59 is 3A, and then 30 to 44 would be 3D. I'm going to have to double check that because I might have reversed the A and B. But so it just splits, you know, the GFR level into two subcategories. Next slide, and the next one after that as well. So this is commercial and Medicaid risk adjustment. So the commercial and Medicaid risk adjustment model is not published. We use DXCG model. It's kind of a black hole. We don't know every condition that risk adjusts, unfortunately. But we currently use the Johns Hopkins model. If you could switch to the next slide. We currently use the Johns Hopkins ACG model, which is very similar to the DXCG model. So they have a little bit more published information. So we've kind of taken conditions from that model and put it on a cheat sheet to let you know some conditions that may risk adjust in commercial and Medicaid that doesn't in the Medicare model. Next slide. So just some examples of that is coronary artery disease, which does have risk value in commercial and Medicaid. It doesn't in Medicare because it has to be with angina in the Medicare population to have risk value. Hypolipidemia, essential hypertension, those are other examples. So these are all examples of those that have risk value in commercial and Medicaid that don't in Medicare. Next slide. And then pediatric risk adjustment, I know because you do have a lot of pediatric patients in your market, I did put together about 4 slides of conditions that have risk value or we believe to have risk value in this population. Next slide. So these are just a list of respiratory and cardiovascular cardiology conditions. You know, asthma is the biggest one that has risk value in the pediatric population that doesn't in the Medicare population. The only thing in the Medicare population related to asthma that has risk value is chronic obstructive asthma, which is the same code as COPD. Next slide, please. These are psychiatry and behavioral health conditions that have value. Bipolar also in the Medicare population, but a lot of these are specific to pediatric or are diagnosed, you know, when they're young. Behavioral health conditions are a very big part of the Medicaid populations, so it is important that we're capturing those on a yearly basis, even if it's, you know, we hope that the behavioral health specialist that's seeing the patient or monitoring the patient is doing it, but, you know, as the primary, you want to make sure that you're making sure everything's being assessed at least once per year. Next slide. These are neurological and rheumatology conditions, cerebral palsy, juvenile arthritis. There's also failure to thrive as a child. Next slide. And these are genetic conditions that a child may have, like Down syndrome or fragile X chromosome, things like that. So we do have a separate pediatric list of common conditions that have risk value. If the practices don't currently have this, we are redoing it for 2021, but we currently have 2020 lists. I can connect with Daryl Garcia just to make sure, because it has been distributed to the markets. I just want to make sure everyone has it. Next slide, please. So these are general documentation guidelines and best practices. So within risk adjustment, it's very important that there is support. There is supporting documentation for the diagnosis code captured, and that is billed because budget is set based on that. They want to make sure that these conditions are being assessed on the day you're seeing the patient, and there's a status update and a plan. Next slide, please. So really the best documentation practices, making sure, the diagnoses are, obviously accurate, they're clear, concise, and described to the highest level of specificity. Quality patient care, this provides quality patient care with better outcomes. If you're sending documentation to specialists, they're sending it, to the primary care physician, or they're ending up in the hospital, having an accurate reflection of the health status, allows for better outcomes. It also allows for accurate diagnosis assignment. So making sure the documentation is there, the coding part of it will be the most accurate based on that documentation. And it also allows for appropriate and timely healthcare provider payment. If there isn't enough documentation, the provider may need to, add an addendum to a note and have to resubmit it. Best practice for a provider is to have complete documentation that outlines the status and plan of care for every condition affecting the patient at least once per year. And as I've said before, the annual wellness visit is where you have the most time and the ability to take inventory of those conditions. But those conditions can be captured at other visits and count toward the budget. Next slide. So the following list provides tips for appropriate documentation. You want to make sure you're documenting all cause and effect relationships. Diabetes with their complications is a major example of that. Report the most specific diagnosis code available. So we try to avoid all of the unspecified codes if you have more appropriate specific documentation. Include all diagnoses evaluated during the visit that affected your medical decision making. Even if they didn't come in for diabetes, if it affected the way you're treating the patient and you had to assess it, then it should be carried down to that final assessment and plan. And then identify diagnoses that are current and or chronic rather than past medical history or previous resolved conditions. Past medical history or resolved conditions should not be captured as active conditions. Avoid unspecified code. I talked about that. Ensure the diagnoses reported are accurate and supported by detailed documentation. And avoid assigning a code in lieu of a documented diagnosis. So you want to make sure you're not just, capturing the diagnosis code, but you're also supporting it in words. And then I went over that. So next slide. You want to avoid abbreviations and acronyms in your practice that aren't used, industry-wide within the medical field. It's hard for someone else who may have to look at that record and know what is being said. So you definitely want to avoid abbreviations just used in your office, because some of them do have multiple meanings. Do not use history of if it's a current or chronic condition that is still present. Or use history of when it's a condition that's actually in remission. And things like in remission could be alcohol dependence in remission, major depression in remission. So these may be conditions that are patients still working on, that still affect the overall health of the patient. And they're not technically historical. And do not document a condition as current if it is historical only, like cancer. If a patient's only being monitored for reoccurrence and they don't have active treatment, or the cancer's been eradicated, you would use history of. And avoid the terms of probable, likely, or consistent with to describe a condition that you actually captured as confirmed. You should only be documenting signs and symptoms until a confirmed diagnosis has been made. Next slide. And I know we only have a few minutes, so I'm going to get through these very quickly. So when you're documenting, you want to make sure that you document the status of the condition, or actually document status code, dialysis, amputation, things like that, even though an amputation, as I've been told many times by providers, they don't grow back. That is correct, but it affects the overall health of the patient on a yearly basis. And since the budget resets to zero every year, we need to tell the insurance companies again. The final diagnosis statement should include all diagnoses that impacted the care on the day you saw the patient, that went into the medical decision making and were evaluated on that date. Next slide. Supporting documentation could include, related signs and symptoms, physical exam findings. Medication list should be documented, and the condition associated with it should be documented. And any results of diagnosis testing that was done for a condition should be documented in the provider's interpretation. If a chronic condition is being followed by a different specialist, then it could be a simple notation that the COPD is under treatment by the pulmonologist. That would be enough for supporting documentation. Next slide. So as well as making sure that you're discussing the status of the condition on the day you're seeing the patient, whether it's to say the patient is stable, they're improving, they're not improving. You also want to make sure that the treatment plan is also documented, whether that be, following up with a specialist, having medication changes, any dietary recommendations, or any counseling provided. And then a final point, diagnosis guidelines require medical coders to apply strict literal interpretation to what the healthcare provider documented. So we're not allowed to connect the dots. The provider needs to make it very clear in their documentation, what this patient has. Otherwise, the coder may have to use the most unspecified code. So the accurate diagnosis code assignment is very important in what, the level of documentation is. And we want that highest level of specificity, or the most accurate. diagnoses. Next slide. So I don't think I have time unless you think I do.
Dina,
Yeah.
I'm going to say that why don't we pause there so that we can wrap up, and then we'll make sure that everyone has gets a copy of the slide deck. So
Okay,
thank you so much. That was fantastic. I would like to end because I wanted to be mindful of everyone's time. So I want to just summarize a couple of things specific to RAF scores, that over the last 2 cycles, so 2 calendar years, we have continued in the Arizona and Utah markets with our risk contracts, seeing our RAF scoring go down. I don't think your patients have gotten miraculously better. I just think we've gotten away from accurately diagnosing the medical complexity of our patients. So part of my plea for all of you today, and to bring back to your practices, is to really accurately reflect the level of complexity of the patients that you care for every day. It's really important. From a Medicare standpoint, the money that we get for our risk contracts is baked for 2020, but not for 2021. So what you do now between November 5th and the end of the year counts for 2021 in terms of that bucket of money that Dina beautifully articulated, sort of the differences of the amount of money we get to care for each of those risks lives. So that's Medicare. For Medicaid and commercial, man, that counts as soon as you get that RAF score documented in terms of the medical complexity today. So it still counts for the 2020 budget and then subsequent year budgets. So really, really critical on those RAF scores. And we're going to be talking a lot more about this as your performance liaisons and local network managers and provider network managers come out and talk with you. I hope this was helpful. I hope for our pediatrician partners who are on the phone today. Yes, I was stalking all of you. That this was helpful. We will get not only the complete slide deck out to you, but also those cheat sheets out to you for both the CPT2 coding as well as for those RAF scoring for both adult and our pediatric populations. You can see on the screen to get your CME and mock point credits, go to this website and fill out the questionnaire so that you can get credit for this. If you have questions for me, if you have questions about the presentation that we need to continue to address, please send them to me, donna.milovitz@steward.org. I will distribute those as well to everyone, not only on the call, but on the distribution list. And again, we have recorded this so that you can distribute this to your other providers for them to hear this really, really important information. Thank you. Thank you for your time. Thank you for your partnership. I know this is clunky, right? It feels hard to do this in your practice. You just want to care for your patients. I absolutely get that. But I think it is really, really critical for us to make sure that we're documenting the value that you will provide every single day for your patients. It really impacts not only the total budget for the money that we have available for these risk contracts, but it also increases the pot of money in terms of that distributable income that we hand back to our valued ACO partners. So again, thank you for your time. Thank you for your partnership, and check your email for all of this information. Have a great great morning. I guess it's not really afternoon yet, and we'll be talking soon. Thank you.
Thank you.
Bye.
Thank you.